let you guys know, as you came into the conference, it automatically mutes you. So if you would like to speak, make sure you unmute yourself for the next few minutes and feel free to chime in. But we are going to give it probably about 5 minutes before we really start kind of going into everything. And we'll give Wendy a second to look and see if we can't figure out what's going on with our video.
Well, I've asked people to talk, so if they wanted to, so their video, it should be everybody, advanced sharing options to all panelists, which is you, us three. So they should be able to see all of you.
Okay. Well, I guess we're the important ones. Just kidding.
We definitely see you.
Awesome. Thank you, Natalie.
As long as everybody can see Kari and you, I think we're good. We have 33 attendees currently.
Okay. Well, we'll go ahead and let people continue logging in. I am going to make some housekeeping announcements. I'll probably make it just a few times for those who are joining now. And then if we have some stragglers, I'll make it again just to make sure that we get through it and everybody gets everything they need to know. So first of all, keep in mind there will be some graphic images since it's going to be on wound care. I know a lot of you are nurses, so you're probably more like me and fascinated with the wounds, but we just wanted to make sure that we give you that little heads up ahead of time to let you know that there will be some images on here. So if you're eating lunch or whatever, just to give you a little heads up that that is going to be going on. I'm sure Kari has picked us out some lovely images to share. Let's see here. Following the webinar, everyone should receive, it will be a pop-up after you close out of the webinar. And those of you who are, correct me if I'm wrong on this, Wendy, case managers, social workers, I believe as administrators as well.
Yes. And RNs, nurses.
Oh, RNs.
Yes.
As a piece of something that we have to turn in for auditing purposes. So just like we offer that at our conferences, we have to offer it virtually as well. And it's important that we get your feedback for us to turn that in for continuing education for you. Correct, Wendy?
Yes.
Okay. So it's important that you complete the survey. And if you don't, feel free to give us an email. Wendy will be happy to help you out. I'm sure most of you all get emails from Wendy as it is now. It will come across as director@cmsa.org, cmsaok.org.
Yeah, .org, yeah.
And let's see here. Once we start doing our presentation, to just keep in mind, please keep yourself muted. Probably what we'll do is once we start the presentation, just go ahead and automatically mute everybody so that we don't have any interruptions like in my house, dogs barking. So hopefully they'll stay quiet for us for a while. If you have questions during the webinar, there is a button on the bottom of your screens if you are on a computer. And if you are on an iPad or an iPhone, it should be up here that you should be able to raise a hand. You can do that, and you can also just do, there's a Q&A. It looks like a little chatting bubble. You can click on that. Feel free to do that anytime throughout the webinar that you want. It will not interrupt, and what it will do is give us a cue that you have a question, and we will go through those questions at the end of the webinar. So it's just a nice little way to keep a list of everybody's questions. The nice thing too is we usually see similar questions, so we can just address them all at the same time. Let's see here. As far as this goes, we will record it and it will be available later on should you want to review it. So for those of you, if you are in between appointments or not in a home office right now, please don't feel that you need to take notes because we will also be sharing the PowerPoint with you. Correct, Wendy?
In a PDF, yes.
In PDF form so that you guys can see it. So don't feel like you need to be mad noting right now. Let's see here. And then also, Kari, if you don't mind, If people have questions and they want to contact you directly, we'll be more than happy to share that contact information.
And I have chat open right now on the side so I can see if anybody is wanting to chat.
And it looks like
We have 40 attendees currently.
perfect. Okay, I can see the chat as well.
Oh, good.
Let's see here. What are my other little notes here? We've done our housekeeping. We do have a couple of our board for CMSA, so I did want to take just a quick minute and introduce a couple of people. So, and I apologize because I have a weird screen, so it's hard for me to see who all is on. But I know I did hear Kurt. Kurt, are you there?
Yes, I am.
Awesome. Would you mind introducing yourself and just who you work for and how long you've been part of the board?
Okay, my name's Kurt Etter, and I'm an RN case manager. Done work comp for 25 years in Oklahoma and have my own business, Mustang Medical Management Services. I left Integris 2 years ago. I worked for Integris for 27 years. And I've been on the board now. I guess this is coming on the second year.
Perfect. And we love having you on the board. Miss Janet Fedor, you are muted right now. If you wouldn't mind unmuting yourself just a quick minute and introducing yourself. Sorry to put you on your spot. I didn't give anybody warning. By the way, you guys are going to be talking during this. She is still muted. Janet, if you are on your phone, it should be on the top part. And if you're down below, if you're on a computer, it should be below a little unmute button. We might have to come back to Miss Janet. She might be multitasking. Do we have Tom?
I don't see Tom.
I didn't see him either. Miss Stephanie Ryder, are you on the board are you on the call?
I'm on. I don't know if you can hear me.
I
Yes.
can hear you. Hello,
Okay.
Stephanie.
I'm in my car, so I'm just listening. I'm driving about, so I'm just listening. I can't do video and drive.
Oh, you're fine. No, it doesn't look like we have video for anyone but the three presenters right now anyways.
Okay.
Totally fine. I just wanted to introduce Stephanie. She's been on the board. I don't know, how long have you been on the board, Stephanie?
I don't know, maybe 4 years?
I'm going to say longer than that because I feel like you've been on the board as long as I have. So it's close to 5.
Maybe 5, yeah, maybe 6.
Stephanie was our president-elect until recently, and with all the craziness going on, she's got some craziness going on and just super busy with her work. So she has stepped out of that role right now, but we are super happy to still have her on our board. She's still actively participating in our board. And so in the meantime, Robert Fuchsa, who's not with us today, he had travel arrangements going on when we booked this. He will be our president-elect going forward. How about tomorrow?
Natalie, I think I'm unmuted.
There she is.
Yay,
Hi,
I
Janet,
think
will you
it's
introduce yourself and tell everybody how long you've been on the board and who you're with?
Janet Fedor. I'm an independent nurse case manager, and I've been on the board probably 100 years since the inception of case management.
I love it.
No, I think I've been on the board 5 or 6 years now.
Very good. Well, thank you, Janet. Let's see here. Miss Debbie Moffett. I didn't see your name on here. I'm not sure if she's on yet. You see her, Wendy?
I see Debbie Moffett. She's on.
Oh.
And
Debbie, can you unmute yourself for a quick second? Introduce yourself.
she should be able to talk.
You might give her a minute. And then Randy Hewlin. Is Randy on?
I don't see Randy on.
Very good. Okay, well, that is our introductions for everybody who's on. I know some people were going to be late joining us, which is totally fine. I know everybody is out and running around and so forth. So that is our board introductions. I am going to touch real quick on, we have had lots of questions. Let me get my notes here. Lots of questions about our continuing education since we had to cancel our annual conference, and we were super sad to do that, but felt it was the right thing to do with the current climate that we're in, and really just to be on the safe side, keep everybody safe and healthy. With the cancellation of our conference, we did start planning this summer to do some CEs. Today is our first of 3. So most of you should already have all this, but I am going to just share with you, since I've got a nice little audience. We've got some great speakers lined up for the rest of this year for our continuing education series. So today we've got lovely Miss Harman. We'll kind of read you about her bio here in just a minute. But also coming up on October 15th, we're super excited. He is one of our favorite speakers. We get more feedback about this doctor than anybody. This will be our 3rd time to have him join us for CMSA, and that is Dr. David Chansom. And he is the infectious disease doctor with Integris, and he's located over at their Southwest Integris location. So he is actually going to talk about the 2020 pandemic for coronavirus. And we actually, we'll get his slides right before, just because everything is so continuously changing. So we will put all that together right before, and so that he can give you guys the most current and up-to-date information of what's going on, new advances, kind of any questions that you guys will have. You might just start thinking about it now, because it's not very often during a pandemic you get some good time with the main infectious disease doctor for, Integris Health Systems. So we're super excited to be able to do that, and so super thankful that he's going to join us, just because everything that's going on, he's incredibly busy, but he loves CMSA and really supports us. So he'll be joining us again on October 15th, and that will be again starting at 11:30, and he'll start talking at noon. And then on November 19th, we've got Mark Pugh. A few of you guys might remember him from a few years ago. He talks about the opioid crisis. So what we've asked for him to come and join us this year is to discuss trends in opioids and medical marijuana, since Oklahoma did legalize medical marijuana since he was here last. So he can talk to us about that. He is just a wealth of information. And for those of you who remember him, he's super entertaining. So we're very excited to have him. One of the sad things about, during this COVID crisis is that we can't be meeting in person, but a nice little bonus is a lot of these speakers that we would have had to fly here, that would have been just very cost prohibitive for us to do, we can do so at this time. And we're excited to be able to offer that to you. So in addition to that, just so you guys know, we are currently planning our 2021 continuing education series. We're super excited to do that. When we know what that's going to look like, we'll share with you. We're still in the beginning planning phases for that. But our goal, just to let you guys know, is to offer at least 1 CE per month next year. And I know I get a lot of questions about ethics. Since we don't get to do all the ethics at our conference this year, we will make sure that at least 1, if not more, of our continuing education for next year will include ethics for you guys. And then also, since we are CMSA, just to remind you guys that if you are a member of CMSA, or if you're not yet a member and you want to become a member of CMSA, you can go to CWCA.org, and they actually have a, hold on just 1 second, I gotta switch over my notes. And they have an education resource library, just to let you guys know that. So they offer 24/7 online access to that library. It has hundreds of pre-approved CEs for you guys. They have a range of course topics from population health, cultural, clinical diagnosis for specific things, professional development, work comp, disability, ethics, outcomes, ROI, tools and technology. I mean, the list just goes on and on. I mean, you guys can kind of see, I printed this directly off of CMSA.org, and they are just a wealth of information. So for those of you that are, struggling not being able to do in-person CEs right now, that is a great resource for all of you. So let's see here.
I did post that on our Facebook page yesterday also. So the link's on there.
Thank you, Wendy.
So yeah.
Let's see here. We talked about that. So I am going to go back just for any of our people who are late joining us. I'm going to go just real quick on our housekeeping announcements, just to remind you guys that this is a webinar on wound care. So there are going to be some graphic images just to share you guys, give you guys a heads up that will be coming. And then also, following our webinar today, you will receive a survey. We do ask that you complete that. That is something that is necessary and required in order to get the CEs. So it's just like if we were doing it in person, we pass those out when you're at the table and then we collect them at the end. This will just literally be when you close out and leave the webinar, it will just be a pop-up. And you'll fill out the questions and hit send and you'll be done, easy peasy. And that way we make sure that we are compliant for everybody receiving CEs today. Let's see here. Once we start our webinar and once Kari starts presenting, we will mute everybody, but please feel free to ask questions throughout. There is a questions box. If you are on a computer, it will be on the lower portion of your screen. If you are on an iPhone or an Android, it will be at the top. And you can do that anytime throughout the presentation. It will not interrupt Kari in any way, but it will cue us and we'll organize those and be able to ask Kari those questions at the end. And I think that's pretty much it. Dee, do you have anything to add? Did I miss anything?
Nope, everything's covered.
All right, well, let's see. Did Randy join us in the meantime?
I have not seen Randy, but there's a phone number on here, but I don't know whose it is.
Okay, and then I think we were missing Miss Debbie Moffett. Is she?
Debbie's listed, but I don't know if she can hear. I mean,
Okay.
I have her unmuted, so.
Awesome. Let's see here. I'm trying to think if we have anything else. Just to make an announcement for everybody to know. First of all, I just want to say we have a ton of new faces and new names joining us today, and we are just so thankful that you guys are joining us on our first virtual CE. We ask for a little grace as we kind of bump our way through our first time. It's our first time being the moderators of a Zoom call. I know most of us have been attendees on a ton of Zoom calls, so we've done some practicing for you guys, but we might have some hiccups, so we just ask that you extend us a little grace as we work through whatever we got to work through. We are super excited to have Kari here. Kari, if you're ready to go, we're a little early, but we can go ahead and get started if that's okay. And are you ready to go?
I am.
Awesome.
Yep.
Okay, well, I'm going to read her bio and introduce her for you guys, just because not everybody knows Miss Kari, although she knows most everybody. So Kari is, I am not going to read all her initials. She is very, very qualified and has a lot of certifications behind her name. So she is beyond exceptional at talking at this topic. So she attended Seminole State College, where she received her associate's degree of nursing. Since receiving her degree, she has worked as a charge nurse, case manager, wound management sales account specialist, nurse case manager, wound education specialist, and most recently, a director of wound management. She has served as a ABWM exam committee member, has been a guest speaker at multiple conferences, and is involved in several wound care professional associations. Kari is married with 3 sons and enjoys team roping. Oh, I did not realize that, Kari. I'm just now reading this for the first time. Super exciting. And raising performance quarter horses when she's not promoting wound education. So she's super well rounded. So I am going to mute myself at this time and pass it off to Miss Kari, and we'll go ahead and get started.
All right, thank you very much for having me. What I'm going to do is I will be sharing my PowerPoint presentation. There is going to be some information added on the slides, and I can update that information if you like. I'm going to be throwing out some numbers just so we have a good representation of how the wound care industry impacts our lives daily. From a financial perspective as well as a nurse case management perspective. I'm going to go ahead and hit my shared screen and then go ahead and start the presentation, and that'll give us about 10 minutes towards the end for questions, comments, or anything that you may need. Just let me know if you can see my screen.
Yep, we can see it.
I'm going to just start the slideshow and transition through. Okay, so today we're going to talk about continuity of care from the hospital to the home regarding wound care. This is something that affects most of us as nurse case managers, whether we are in the hospital setting, LTAC, acute, or work comp. So some of the objectives today are going to be to discuss the transition from hospital to home. We're going to define and describe what homebound means. We're going to describe the role of PDGM, which is the new payment system for home health agencies that just took effect in January of this year, and identify some common wounds, different categories of dressings that we would cover those wounds with, understand advantages and disadvantages of different types of dressings, recognize appropriate dressing selection based upon wound preparation and presentation, and select appropriate dressings for example wounds. So homebound, what is homebound? Well, in a nutshell, Medicare defines homebound that you leave your home infrequently for only short periods of time, and that leaving the home requires a great and taxing effort. Patients are allowed to leave home for medical appointments, church services, and once-in-a-lifetime occasions such as weddings, funerals, and etc. Generally, it also includes in the definition that you need help from another person or medical equipment such as crutches, walkers, wheelchairs to leave your home, or your doctor believes that your health or illness could get worse if you leave your home and it's difficult for you to leave your home when you typically cannot do so. To summarize that, basically, you cannot go to the movies. It's the inability to do normal tasks. And generally you have to have a skilled need in order for that to be determined by CMS as being homebound. So wound care and home health, what does PDGM mean to you? So if I'm speaking to the discharge planners from LTACs and hospital setting, that means that with the new payment system of home health, we are, as a home health agency, able to accept your patients with the ability to provide better care and more advanced wound care dressings. They are also broken down into patient-driven group models. Wound care is now one of the top 5 diagnoses according to PDGM, and what this will do is facilitate earlier discharges from hospitals and also help prevent rehospitalizations. Why does home health get a bad rap? And you may wonder, why would I bring that up? And I think as a culture in nurse case management, we're discharging, admitting, and things of those nature. Sometimes when the patient is sent home with home health, there are a lot of home health agencies to choose from, and wound care has not always been a strong suit for home health agencies. With the recent transition to PDGM, that allows home health agencies to have actually more reimbursement to take care of those patients, because what we're seeing is we're seeing more acute patients and a different variety of wounds, and wounds that typically are a little bit more labor intensive and cost prohibitive to take care of. So as we transition from some of the challenges with home health, a couple of things that are super important is whenever that patient gets ready to be discharged, that we have clear orders on either to evaluate and treat, Some of the other issues that we run into that are commonplace in home health are patients that don't frequently see a primary care physician. Maybe the primary care physicians aren't up to date on current wound modalities. Sometimes the patients are going to wound care centers, and there oftentimes can be a gap of communication with them as well. So we all want to collaborate and work together on making sure that the patient has the best outcomes when it comes to wound care. Some of the things we're going to start talking about now are common types of wounds. And the most common what we see are pressure injuries or ulcers, stage 1 through 5, stage 1 through 4, neuropathic ulcers, diabetic ulcers, venous ulcers, arterial ulcers, skin tears, and surgical wounds. So the first category we're going to talk about are pressure injuries. These used to be termed as pressure ulcers, but last year the terminology changed to injuries versus ulcerations. So it's important to know that injuries occur over bony prominences, and you can see the list. Generally, occiput, ear, scapula, spinous process, shoulder, elbow, iliac crest, sacrum, coccyx, ischial tuberosities, trocaners, knees, malleolus, heels, and toes. So if you think about that, and you think of the mechanism of action of a pressure injury, it is over an area where the tissue has become compromised and there's lack of tissue oxygenation, therefore causing tissue death. So within pressure injuries, the first stage that we see is the stage 1. This is intact skin, so there's not a break in the skin, and it's non-blanchable redness of a localized area, usually over a bony prominence. Again, what has occurred is there has been pressure applied to that bony prominence, and oxygenation has been compromised, therefore causing tissue trauma. Darkly pigmented skin may not have visible blanching. Its color may differ in the surrounding area. This area may be painful, firm, soft, warmer, or cooler as compared to adjacent tissues. Stage 1 injuries may be difficult to detect in individuals with dark skin tones. And you can see with the example at the bottom what blanchable means. Stage 2 pressure injuries. So these are a partial thickness loss of the dermis, presenting as a shallow open ulcer with a red-pink wound bed without slough. You can see the pictures. Typically, we are not going to document this as a full thickness injury, and it's only going to be partial thickness. It can also present as an intact or open ruptured serum-filled blister. A stage 2 ulcer injury may also present as a shiny, dry, shallow ulcer without slough or bruising. This stage should not be used to consider to describe the skin tears, tape burns, perineal dermatitis, maceration, or excoriation. And then you can see some of the graphic pictures at the bottom of the screen. Stage 3 pressure injuries. So these are full thickness tissue loss. So subcutaneous fat may be visible, but not bone, tendon, or muscle. Slough may be present, but does not obscure the entire tissue of the wound. And stage 3 injuries may include undermining and tunneling. Epibole can be present, and epibole is where the edges are rolled. And if you look at the top, this one right here, you can see, and also down here at the bottom. Can you guys see me move my mouse? Wendy? Yes, you can. Okay, all right, so this is epibole where the edges have rolled, and that means that they have already epithelialized, and it's going to be difficult to have that wound granule up to the top and then epithelialize across the top of the wound and actually fully close. The depth of the stage 3 pressure injury varies by anatomical location. So basically, to summarize that statement is that if it occurs over an area where there's not any subcu or adipose tissue or fat, those pressure injuries are going to be thinner. So a lot of times we think when we see a stage 3, it's only over thicker areas of the body, but it actually can occur quickly over areas that do not have a lot of adipose tissue. Again, bone tendon is not visibly or directly palpable. So with a stage 4 pressure injury, these are full thickness tissue loss with exposed bone, tendon, and muscle. Slough or eschar can be present, often includes undermining and tunneling. The depth of the stage 4 varies by anatomical location, again, where you don't have a lot of extra tissue. They can present as more of a shallow wound than deep. Obviously, if it's on the, your trochanter where you have more tissue, it will likely be a deeper wound. Stage 4s can also extend into the muscle and or supporting structures such as fascia, tendon, joint capsule, and bone. With stage 4s, that's when we start to be mindful that osteolysis may occur, and an osteomyelitis is infection of the bone. Exposed bone and tendon, again, may be visible or directly palpable. Unstageable. So this is what happens. We have a full thickness tissue loss with the base of the ulcers covered by yellow slough, tan, gray, or brown, and or eschar, tan, black, or brown in the wound bed. Basically, we can't see what is at the base of that wound. That's why it's considered unstageable. Until the slough and or eschar are removed to expose the base of the wound, the true depth and stage cannot be determined, and it will either be a stage or a 4 generally at that point. Stable, dry, adherent, intact, without erythema or fluctuant eschar on the heels serves as the body's natural biological cover and should not be removed. So you can see these two photos down here in the corner. Oops, I went back. Okay, these pictures down here at the bottom, those are considered stable eschar and unstageable because we can't visualize the depth of the wound. Deep pressure tissue injury. So this occurs when there's actually not a break in the skin yet. The wound has not declared itself, if you will, so we're not really sure at this point. We know that there is deep tissue injury. However, we don't know the depth of that injury and if it will manifest and actually open. So these present with purple or maroon localized area of discolored intact skin or blood fluid filled blister. That's a lot of B's. To damage of underlying soft tissue from pressure or shearing. Again, presentation may be preceded by tissue that's painful, firm, mushy, boggy, warmer, or cooler than compared to the adjacent tissues. That may be difficult to detect in individuals with darker skin tones. And the evolution may include a thin blister over a dark wound bed. The wound may further evolve and become covered by thin eschar. Evolution may be rapid, exposing additional layers of tissue even with optimal treatment. So with deep pressure tissue injuries, sometimes you just don't know until it opens exactly what you're dealing with. However, with all pressure injury, the primary treatment is to reposition the patients. You have to redistribute the pressure either by offloading, using pillows, low air loss mattresses. We're not going to be able to, once the injury has occurred, if you will, then we have to do a plan of care that will actually treat the wound. But first line defense is to avoid that tissue injury in the first place by repositioning. Other types of skin conditions are moisture-associated skin damage. Just to summarize, this is caused by prolonged exposure to urine, stool, perspiration, when exudate, mucus, or saliva. Can be caused by irritant dermatitis, diaper dermatitis, and diaper rash, perineal dermatitis, and includes interrogous skin-related issues. So this is caused when a patient, it's not pressure related, it's because they have had body fluids that have been against the skin for too long, and they basically erode the epithelial layer. Other types of skin conditions are medical adhesive related skin injuries. Basically what happens is these are caused by tapes, Foley catheters, and things that actually are on the skin. And either you can be adhesive related, or it can be related to just a medical device being pressed up against the skin. Skin tears. These are wounds caused by friction, shearing, or blunt force trauma that result in separation of the skin layers. If we're providing wound care on a patient with a skin tear, it's recommended that we document those as traumas, and they're going to generally be full thickness or partial thickness. Lower extremity wounds, arterial, venous, and neuropathic ulcers. So arterial ulcers, venous ulcers, and neuropathic, or also called diabetic foot ulcers. We have approximately 3.2 million Americans, which is 1 in 800, are affected by leg ulcers. 70–80% have venous insufficiency, which includes 2 to 4% of the adult population. 5 to 10% have arterial insufficiency, and then 5% have diabetes or neuropathy. And then there's also atypical wounds, which make up 5% of the others. So with arterial ulcers, basically what happens is they have a compromised blood flow to the lower extremities. They occur distally or on pressure areas as well, including the toes, heels, malleoli, tibial shins. Well, and they generally present with well demarcated edges, classic punched out appearance, often with overlying necrotic eschar, and they're typically painful. And you can see these different pictures, how when I say punched out, it's actually round and pretty well defined. So what's happened is that we see a picture of the normal artery and then a diseased artery. So we have lack of tissue perfusion to that lower extremity. With venous ulcers or venous stasis ulcers, these are caused by a dysfunction in the venous system where we can get blood flow to and oxygenation to the extremity, but we cannot get it pushed back out, which causes venous hypertension. Prolonged venous hypertension results in vessel and injury damage. This increases capillary permeability and allows the extravasation of micromolecules and macromolecules into the surrounding tissue. Damage to these tissues leads to venous ulcer development. So what happens is we get the oxygenation in the blood to the extremity, but we can't, because of incompetent valves, push that back out. The gold standard of treatment for venous stasis and venous insufficiency is compression. Neuropathic or diabetic foot ulcers or injuries, the causes are generally because we have lack of sensation in the neuropathic or diabetic foot. We have a loss of the protective sensation, so these patients can't feel the bottom of their feet, and they walk around the house, they step on a Lego, attack, or they go out to get the mail in their Crocs. Next thing we know, they've stepped on a nail in the driveway, they didn't feel it, which leads to infections. Repetitive mechanical stress and excessive pressure also can cause diabetic foot ulcers. Poorly controlled blood glucose levels significantly affect the ability for the wound to heal. It also accelerates the development of arterial disease. Some risk factors include smoking, location. Common sites are the toe, interpharyngeal joint, metatarsal heads, plantar surface of the foot, which is the bottom of the foot, and under the heel. So now that we've talked about some of the most common wounds that we see, we're going to talk about dressing selection. And dressing selection begins with wound bed preparation. So basically, to summarize, when we talk about wound bed preparation, we want that wound bed to be free of devitalized tissue, which is slough or necrotic tissue. That's the first thing that we have to do. And so when we start preparing our plan of care for wound bed preparation, we have to remember that there are over 6,500 products on the market. Again, 6.5 million people are affected by non-healing chronic wounds in the United States. $50 billion is spent annually on the treatment of wounds, with the average cost of $3,927. And we're expecting a $43,000 increase on just pressure injuries alone for hospitalization. So it's kind of a big deal that we try to prevent injuries and then treat them as effectively and as quickly as possible. Some of the things to consider are related factors such as etiology, severity, environment, size, anatomic location, and infection. Patient-related factors such as what is their vascular status? Do we have a vascular physician on board doing the testing for us and making sure that we have a correct diagnosis? Patient-related factors include vascular status, medications, and nutritional status. There's a host of medications that compromise the ability for the wound to heal, such as long-term steroid use, nicotine, smokers. Generally have a more difficult time healing than your non-smokers. And then dressing related factors such as availability, durability, and then characteristics of that dressing, and then the cost of the dressings. So when putting this together, there's a variety of mnemonics out there that we can use. I chose to use the DIMES method, and we're going to transition through each of these letters to talk about what we're going to do and the goals for that particular letter, and then corresponding dressings. So DIMES is for debridement, infection, moisture balance, edge, and supportive products. It's important to know that we have to make sure that the wound is free of necrotic tissue before the wound can actually start the healing process. And if you look at the slide at the bottom, it talks about the cascade of the wound healing event, starting with hemostasis, where we have a blood clot, then the inflammatory phase where we have fibroblasts, macrophages, and blood vessels are starting to come in and start cleaning that wound up. Proliferation phase, that's when the wound starts healing from the subacute tissue up, and then remodeling phase, which can actually be up to 2 years. We're going to go through each of these acronyms and apply them to everyday wound assessment, dressing selection, and application. So the first letter that we talked about is going to be debridement. And so the primary method of debridement, we're going to use the BEAMS mnemonic. So the first thing we have to do is quickly and safely remove necrotic tissue, which is slough as well. There's 4 types of debridement, which include biological, sterile maggot therapy. I'm not going to show you any pictures of maggots, I promise. So if you're eating lunch, you don't have to worry about seeing that. Enzymatic, which is a collagenase, an enzymatic activity. Autolytic, which include hydrocolloids, hydrogels, and transparent films. Mechanical, wet to dry or moist to dry. And then sharp and surgical debridement, which are usually carried out in a wound care center or a hospital environment. So the first we're going to talk about is autolytic debridement, and this is the process that the body undergoes to remove dead tissue. During autolysis, enzymes present in the wound and have the effect of liquefying that non-viable tissue. Physicians foster autolytic debridement by utilizing moist wound care dressings. Some moist wound care dressings include transparent films, hydrogels that can be impregnated with silver, which are antimicrobials, hydrocolloids, and medical grade honey. You can also see up at the top different pictures of hydrogels, transparent films, and then a stream of medical grade honey. So the next thing we're going to talk about is enzymatic debridement. So what happens with enzymatic debridement is it's a topical prescription that contains collagenase enzymatic enzymes that work from the bottom up to selectively degrade or dissolve non-viable collagen. It breaks down only the denatured collagen, leaving other proteins unaffected. It also does not harm the collagen needed to form a scaffold, which is crucial for the healing process during the second phase of the wound healing cascade. This particular product can be applied by a skilled nurse, or actually can be applied by caregivers for the patient. And it is a prescription product that may be covered by health insurance companies, Medicare, and Medicaid. You can see with this particular patient, we started the collagenase enzymatic debridement ointment on 7/24, and less than 30 days later, we were able to get that devitalized collagen, Slepper Eschar off of there and start a more progressive wound treatment. With mechanical debridement, this is considered your wet to dry dressings. It uses an external force great enough to separate or break adhesive force of necrotic tissue. And this is non-selective, and so it's going to take any and all tissue whenever you remove it. It's generally painful to the patient, and its contraindications include epithelializing wounds and granulating wounds. So we see this from a lot of patients that have undergone a surgery. It's still fostered by surgeons whenever they're trying, maybe they have a dehisced wound and it has some necrotic tissue. The thing that we need to keep in mind is that it really should only be used for a limited amount of time. Once we get that devitalized tissue off of there, we can then initiate a more progressive wound care treatment. There are a couple of solutions besides normal saline that we're seeing trending in wound care that are also used in wet to dry or moist to dry, and those include acetic acid, Bacons, and hypochlorous acid. The next form of debridement we're going to talk about is sharp or surgical debridement. So sharp debridement is facilitated by a skilled clinician and certified in debridement. I am actually certified in conservative sharp debridement. So that means that I can receive an order from a physician and clean the wound up, if you will, using a curette, a scalpel. They're all sterilized instruments. The level of debridement varies on the level of necrotic tissue that needs to be removed. Debridement is facilitated again with the pictures that I've showed, the curette, scalpel, scissors, and forceps. This can be completed in clinical setting or at bedside. And then surgical debridement is the most aggressive and usually performed in the operating room. So the next one we're going to talk about is infection. So a wound infection occurs when bacteria breaks the skin. Signs and symptoms include pain, induration, erythema, increase in exudate drainage, odor after cleansing the wound, and discarding the dressing. Bacterial burden can delay the healing process by leading to infection and inflammation in the tissue. Silvadene, although commonly prescribed, is not effective against MRSA and is only effective for 4 hours, requiring frequent application. So, Silvadene is a commonly written wound care treatment for patients with any and all types of wounds. Generally, we see it written for burn patients, but primary care physicians are still writing those orders. When you see Silvadene written for your patient, you may want to team up with a wound care specialist or maybe the wound care center and get a second, not necessarily a second opinion, but just see if there's something a little bit more progressive that you can use on that wound. Along with Silvadene, we also have other antimicrobial and antibacterial agents, such as Bactroban or Mepicin ointment, hypochlorous acid, PHMB, which is polyhexamethylene biguanide, catahexamer iodine, chlorhexanide gluconate, ginseng violet or methylene blue, acetic acid, and then citramide. These are all just this is not an all-inclusive list of the antimicrobial and antibacterial agents on the market, but it is just encompasses some of the ones that are frequently prescribed or orders that are written. So next we're going to talk about the kind of falls within the infection and bacterial mode of the wound is biofilms. So biofilm comprises of a centropic consortium of microorganisms which stick cells together and to each other, and often also to the surface of the wound. These adherent cells, sometimes embedded with a slimy extracellular matrix, is composed of extracellular polymeric substances. So basically, you're wondering, Kari, why are you talking about a biofilm? What happens when we have a biofilm, and is that A lot of the topical standard treatments don't penetrate a biofilm. And so when we have a non-healing wound, one of the things that we need to address when we're looking at that wound bed preparation is what's going on? Why is this wound not healing? We're using these progressive treatments, but it's still not getting better. Outside of addressing the comorbidities and lifestyles for the patients, we need to suspect that a biofilm is present. Some of the products that I mentioned earlier, and we'll transition through some of those as well. Generally, if you will coordinate with a wound care center or a wound care specialist, we can help transition and rule out biofilms and provide recommended treatments for those. The next thing we're going to talk about is moisture balance, which is very important in the wound bed, because if we have too much drainage or not enough, that's going to stall the wound out. There's a wide range of products that support moisture balance. So the thing to take away from this particular slide is that if it's dry, let's donate some moisture. If it's wet, let's manage that. If there's too much drainage, then we want to manage that with a different category of dressing, such as foam, superabsorbents, gelling fibers, alginates, and things of that nature. It's important that whenever we're documenting about wound drainage, that we document specifically if it is scant, minimal, moderate, or copious. We also want to document what the color of that drainage will be, whether it's serous, sanguinous, serosanguinous, purulent, or seropurulent. We want to make sure that when we're assessing the drainage, maybe you're attending a wound care visit with a patient, or they call you and tell you that their wound is stinking or it has an odor. We want to make sure that when we remove that wound care dressing, that we cleanse the wound completely before we assign if there's odor or not. Because a lot of times some of these dressings can actually, the drainage in the wound bed in the wound dressing will actually smell, and it's not actually the wound itself. So we don't want to assume just because there's odor on the dressing that patient actually has an infection. Other considerations when we're talking about moisture balance and dressings is the cost and frequency that we're having to change those dressings. We have pretty much gotten away from BID and TID dressing changes. What we've learned is that the longer we can leave that wound undisturbed, it will allow migration of those cells. I liken wound healing to baking a cake. One of the first things that you do when you decide you're going to bake a cake is you make sure, obviously, that you have all your ingredients, but then you're going to go ahead and preheat your oven. Once you get the cake put together and put it in the oven, what happens if every 15 minutes you open that oven door? You lose heat. Same thing happens with wound care. The longer we can leave it undisturbed, as long as there's not a risk for infection and the drainage is being maintained or monitored, the better chance that we have for that wound to heal and fewer traumas that will occur. So within moisture balance, we talk about moist wound healing. That's just where we're going to donate moisture to that wound bed. You can see a list and a host of advantages. Basically, moist wound healing is the gold standard when we're trying to get a wound to heal up. Fewer dressing changes are more cost effective. Some of the dressings for moist wound healing actually have a waterproof backing on them. They decrease, the pain is decreased with moist wound healing, decreased edema, and also better cosmetic results. And it also enables the body to heal at peak efficiency. So the first category we're going to talk about with moist wound healing is transparent films. These are your thin films that, when we work in the hospital, we would secure maybe their IVs with these. They work pretty good in the wound care setting as well. You can actually combine them with other dressings to cover a wound. They are indicated for light exudate only. We want to make sure that their peri-wound or their skin is intact. We don't want to put a dressing on them and cause an additional injury. Sometimes they can be difficult to apply because they are super sticky. And here are some pictures down at the bottom that a transparent film would be appropriate for. Hydrogels. So hydrogels are basically quick water or quick glycerin. They can come in a variety of forms, such as hydrogel sheets, just gel, and impregnated in gauze. They basically are going to donate moisture to that wound bed. And that's what we want when we're trying to achieve moisture wound healing. Advantages, they have a good moisture vapor transfer rate, which basically is that some of the vapor can evaporate off the top of the dressing, facilitates autolytic debridement or autolysis, soothing, good compatibility with peri-wound tissue. It's not going to cause any trauma, and hydrates the bed. Some of the disadvantages is you have to use a secondary dressing with a hydrogel sheet. You can't just put a dollop of hydrogel on the wound and leave it. It has to be covered by something. If it's already a heavily draining wound, a hydrogel would not be the most appropriate dressing for that, because at that point we're going to be trying to the amount of drain. And again, it does require secondary dressing. And this picture down here at the bottom, it would be certainly appropriate for a hydrogel. Hydrocolloids. So hydrocolloids are another dressing category. Composition varies. They're usually a gelatin-based pectin carboxymethylcellulose. They come in a wide range of shapes, sizes, anything from pads, pastes, and powders. And these are occlusive and sometimes semi-occlusive. You can see the advantages versus the disadvantages. They do provide a bacterial barrier. They are appropriate for moderate exudate absorption, decrease pain in the wound, facilitate, again, autolytic debridement or autolysis. They are self-adherent and they're pretty inexpensive. Disadvantages is sometimes if they're not a high quality hydrocolloid, it can leave some of the residue behind and be difficult to remove. We can't visually monitor the wound, and they're certainly not indicated for infected wounds, wounds that have tracts, exposed bone or tendon, and oftentimes they are adherent or tacky. And you can see that there's some pictures down here at the bottom where a hydrocolloid would be appropriate. I'm just trying to check my time. Okay, all right, so the next category we're going to talk about are for moderate to heavy drainage, and they include foams, which come bordered and non-bordered, super absorbent dressings or specialty absorbent dressings, calcium alginate, ABD pads, and hydrofibers with or without silver. Border dressings can include a silicone, transparent film, or an incontinent barrier type adhesive. They can also be incontinent proof, if you will, or water resistant, and those are typically used for patients that have incontinence issues. We need to be mindful of the peri-wound integrity, which is generally the area outside of the wound, 2 to 4 centimeters. So you actually have your wound bed, and then outside of that is the peri-wound area, and that sometimes can be compromised related to incontinence issues and pressure-related issues. Again, all of these in this category can have some antimicrobial properties and can be left on from 3 to 7 days. So the first in this category of moderate drainage would be calcium alginates. They are a derivative of seaweed. They can come in ropes and pads. Calcium alginate absorbs 20 times its weight in fluid, so you're not going to use these on a minimally draining wound. They are biodegradable, and these also too can be impregnated with silver and or other antimicrobial properties. Advantages, we can use it as an absorbent and a filler. It's biocompatible with the peri-wound tissue. Generally, there's no trauma to the wound bed with removal. It'll facilitate autolytic debridement, and it's generally cost effective. Disadvantages is if we're overutilizing it or we're not using it on the appropriate wound, it can be more expensive. We can't see the wound. Sometimes the gel can be mistaken for infection because it can turn kind of a yellow hue. And then we definitely don't want to use these on dry wounds, as it can cause desiccation and dry that wound out, which is the last thing we want to do. And here is an appropriate picture for calcium alginate. Foam dressings. So with foam dressings, they can either be a cover dressing or an actual filler. They can be a primary or a secondary dressing. Primary being the dressing that goes actually against the wound bed, and the secondary is what covers up that wound, covers up that particular primary dressing. They do come with or without adhesive border, varying thickness and absorptive capabilities. Some of them have a polyurethane film coating, and these two can be impregnated with antimicrobial agents or silver. Again, advantages versus disadvantages. They are great for absorbing drainage. They have good moisture vapor transfer. Some of them allow the some of the drainage to be evaporated off the top. Good O2 permeability, minimal trauma to granulation tissue, and they support autolytic debridement. Disadvantages, again, we can't see the wound. They can stay in place for a while. We don't want to use foams that are already dried out, if you will. Again, they may require secondary dressing, and we're not going to put foams on wounds that have dry or stable eschar. And then this is a picture of a wound where we would use that enzymatic collagenase ointment we talked about earlier to remove some of that slough off the top of the wound, and then we could cover that with a foam dressing. All right, so when we're looking at dressing choices, we want to look at, this is just a great slide, if you have slight drainage to heavy drainage, and the types of dressings that would be appropriate for that amount of drainage. So the next thing we're going to talk about is edge or environment. So we've debrided, we've addressed infection, we've addressed moisture. Now we're trying to get that wound to the absolute healing stage. So not all wounds will respond to traditional treatment methods, and when wounds become stalled, a more advanced treatment modality may be required to help improve the wound healing environment. I don't consider collagen as an advanced treatment anymore. I consider it is in my everyday bag. I feel like the sooner collagen is initiated in the wound healing process, the better outcomes that we have. And so what we need to remember is that our body is made of collagen. And what the wound care industry has figured out is that we can manufacture collagen. It's typically derived from bovine, equine, porcine. It promotes granulation tissue formation. It stimulates new tissue development and supports autolytic debridement. And it reduces the matrix metalloproteases in the wound bed. It comes in a variety of forms such as gels, pads, ropes, and powders. And here's some pictures of different types of collagens that are out there. They also are impregnated with other types of antimicrobial properties, and also properties that combat whenever a wound has too many matrix metalloproteases in the wound bed. Advantages, they can be absorbent. They can also be combined with a calcium alginate. They facilitate autolytic debridement. They support a moist wound environment. They're not adherent, easy to apply. They may be combined with other topicals. They are biodegradable. They're not recommended for full thickness burns because of the risk of hypergranulation, and they're not recommended for black, dry, or stable eschar. If we don't have any moisture in the wound and we can't break through that eschar cap, if you will, donating collagen at that time is probably not going to be beneficial, and they require a secondary dressing. And you can see these pictures at the bottom would certainly be appropriate to apply collagen sheets and cover with a foam dressing or the collagen powder as well. So gauze dressings are probably one of the most commonly provided dressings on the market. They are inexpensive, but one of the things we have to keep in mind when treating a wound is cost versus price. If you're having to go out and do a dressing change 3 or 4 or 5 times a week, and we're using a cheaper wound care dressing, that doesn't necessarily mean that it's positively affecting the bottom line. It's also certainly not providing the most advantageous outcome for our patients. Gauze dressings we can use them to clean the wounds. They come sterile versus non-sterile. Pads plus strips and rolls. They can be impregnated with water, saline, Vaseline, iodine, and silver and other antimicrobial properties. And they come with or without adhesive border. Advantages, again, gauze dressings are used for wet to dry. They are permeable. The one thing that we have to keep in mind when we see orders for gauze is that you can take a 64-layer stack of gauze dressings and microbes can penetrate it. So they don't have, unless they're impregnated with an antimicrobial, unfortunately, they have the possibility of exposing that wound to infection. Disadvantages may be ineffective, just related to the microbial inability to control microbes. Damage viable tissue, painful to remove, dehydrate the wound. So if we put gauze on an already dry wound, it's not going to facilitate moisture to the wound bed. It can dehydrate. Again, it's permeable to bacteria. If the wound is too moist and we put gauze in there and we're not managing it with one of the other types of dressings for moderate drainage, that gauze, when it's saturated, can actually macerate the wound, which means there's too much moisture there, and it's usually like a kind of a white color around there. It makes you kind of a pruny look. If you stayed in the bathtub too long, how your fingers will get pruny. That's what maceration looks like. And they're not cost effective if you're having to go out more often and change those dressings. So composite dressings are another category where they combine two physically different components into one dressing. They are for minimally draining wounds. They do have a bacterial layer, so unlike gauze, they will help ensure that the wound environment stays free of infection. They have an absorptive layer other than alginate foam or hydrocolloid or hydrogel. So usually what's behind that bacterial layer is just a very small filler that only wicks away minimal drainage. It does facilitate autolytic debridement. It does foster moist wound healing. It's easy application and removal, and they can be a primary or secondary dressing. The thing that when we talk about border dressings, we want to make sure that that peri wound can sustain an adhesive dressing, or make sure that we're not going to cause trauma to that peri wound by creating another wound. So additional therapies that we can see, and that is in wound care, or antimicrobials. We talked about that list of silver, PHMB. When we want to be mindful that when we're treating patients with antimicrobials, that we are stewards of antimicrobials, and that we're not constantly throwing silver or antibiotics on wounds unless we know that there is truly a clinical indication to do that. The next thing we're going to talk about is tissue engineering. So what that means is that we have in the wound care industry been able to make skin substitutes, if you will. I'm getting to my notes, and I was looking to see how much time we have left. Since we started early, what do I have, about 10 minutes left, Wendy? Okay, all right. So with tissue engineerings, we have the equivalents for those are Apligraf and Oracell. And the reason I'm saying those particularly is that you just may have heard those terms whenever you may be discharging a patient from the hospital or long-term care facility. An important thing about tissue engineering products is that we want to make sure that there's a moist wound environment. We don't want to, when removing those types of dressings that are covering those, we want to make sure that we're very careful that we don't take away that engineered tissue, because they're pretty expensive. And so we don't want to damage that preparation of the wound bed by using those types of products. Growth factors, hydrofiber dressings, surfactants, super absorbent dressings, we touched on those a little bit, and then negative pressure wound therapy or wound bags. So here are some additional therapies. Wound vacs have been at the forefront of wound care for a long time now. I've seen probably within the last 10 years, they're used a whole lot more than when I started my career early on. And we've used wound vacs to help manage the drainage in a wound. It also stimulates granulation. These typically are covered by the insurance company. When they're discharged to home health, that's definitely a skilled need. You don't generally see patients doing wound vac dressing changes, and they're very effective for closing wounds up. Then we have super absorbent or specialty absorbent dressings. These just basically are dressings that have been engineered to form a gel, if you will, against the wound bed, providing moist wound healing. And they can come in a variety of forms as well, with adhesive borders and without adhesive borders. And then hydrofibers are a technology to where they are also impregnated or can be impregnated with silver, and they are going to wick drainage away as well. But they're going to maintain a moist wound environment for that wound to heal appropriately. So with dressing considerations, you want to ask yourself, is the wound free and clean of infection? Is the wound wet or dry? What we've learned today is how we can address the wound from injury to healing, and a wide variety of dressings in between. These questions are going to guide your dressing selection and topical medications and possible use of other modalities such as wound vacs and so forth, tissue engineering, and growth factors. We want to consider the cost-effective efficacy in treatment planning, minimizing pain and wound disruption, caregiver time, and then also we want to make sure that we're not using the dressings inappropriately. One thing that I always educate on is if we're having to moisten a wound if we're having to moisten a dressing to remove it from the wound, that may not always be the most appropriate dressing to use at that time. There's my list of references. So that pretty much concludes putting a whole lot of information in 1 hour. Generally, this is a class that I would teach over the course of an entire day. So I really just tried to hit the hot points, if you will, as far as wound care, description, modalities, and dressing selection, and then also what type of wounds we see out there. Are there any questions?
We do have one question from Kurt Ederer, and his question is, how important is a high protein diet in expediting the healing process? Excellent question, Kurt.
That is an excellent question. It's very important, and there's a lot of things I didn't get to hit on. High protein is very important. You know, those are things that if you're inpatient or even long-term care, acute, and in home health setting, we want to make sure that they have adequate protein. We can do that by drawing labs, just albumin and a pre-albumin that will tell us what their protein needs are. Anytime that we're doing a nursing assessment, we want to make sure that we are addressing their nutritional needs. Another component that we sometimes overlook in our diabetic population is that generally any time the patient has consistent blood sugars over 150, it starts to significantly impair the wound healing process. So whenever we're managing, we need to think about this, and I know it kind of probably sounds a little cliche, but we want to treat the whole patient, not just the hole in the patient. And so we have to look at the big picture And I would encourage you that if you don't take anything else away from this, coordinate with a wound care specialist. You can go to, you can Google wound care specialist, and it'll pull up a variety of different associations. And then you can key in your information, and you can find a wound care specialist local that can, and we're always wanting to help each other. And so if you reach out to me, if I don't know the answer, I have got a network of colleagues that I can reach out to. Because obviously I don't know everything. So I encourage you to reach out and utilize us, because that's what we live for. We're kind of gross, as you saw some of those pictures. We want to help. That's why we've done what we do and gotten the certifications that we have, so that we can help heal the world one wound at a time.
Yeah, we've got another question from Susan Long, and that is, what are the indications that open to air is appropriate?
Never. It's never indicated.
Great question. We've gotten this question a couple of times, and I'll take this one because it's an easy one and it's not clinical, which is, can we get the notes of the presentation on this? And we are going to, at the conclusion of this, we will change the presentation into a PDF, and we will email it out to all participants. So feel free to put some notes on there if you want, but you guys all will get a copy of that.
And I believe Jill Fry has a question. She has her hand up, so.
Uh-oh.
Yes, I have trouble. Hi,
Jump
Miss
in,
Kari.
Hi, Jill.
Listen, hello, dear. I have a question for you, and I'm not at my desk, so forgive me. But I have a claimant in an LTAC with a serious wound, and he's been on I'm trying to remember what she called it, a low air bed.
Low air loss mattress?
Say it again.
Yes. A low
Say it
air
again.
loss mattress?
Yes. And their treatment plan, they haven't been turning in properly, I don't think, and we've got something set up for that. But they're gonna upgrade him to something called and this is what I'm not sure of, an Escala bed. She said it's the Cadillac of air beds.
Fluidized bed.
Do you know anything about its effectiveness over and above the prior bed we discussed?
So what I'm going to talk about real briefly, Jill, is that even though you have these patients on those beds, they still have to be repositioned.
Right.
So, I mean, definitely there's certain criteria that you have to meet to be able to get those Cadillac, if you will, of beds. But at the end of the day, this patient still has to be repositioned. You still have to reduce that pressure.
Right.
You have to reduce the pressure. And even though you have beds that alternate pressure, where they have the chambers that pump up and go down sequentially, or if the patient moves in the bed, even the ones that tilt them from side to side, it's still the skilled nurse's responsibility, or family or caregivers, to reposition that patient.
Right, and I think we've got a plan in place that theoretically should work for that, and so I'll wait and see when the guy goes back to the facility. Are we allowed to say something favorable about a professional LTAC, or is anybody allowed to tell me who their favorite is?
If you want to shoot me an email, I can send you some recommendations.
I'd be thrilled. Did you say you wanted me to email you?
Yeah, just shoot me an email or text me.
Okay.
Yeah, and we'll send
Good
out her
idea.
email contact information at the end of this. We do have one other question from Cindy Fleming, and her question was, how do you deal with a physician that just won't listen? You know, a wound needs an AG and the doctor is against AG dressings, period, the old school doctors. Do you have any recommendations for that, Ms. Kari?
Well, we deal with them daily. What I find is education, and what I would encourage you to do is reach out to some of the industry professionals, even maybe some of the wound vac reps, some of the wound care reps that are out there. What I find is if they're not willing to listen to you directly, if you form those relationships, time's up. If you'll form those relationships with some of your representatives, then they oftentimes have established relationships with these physicians, and they bring them bagels, and that makes the physicians happy, and we can just kind of sneak our recommendations in the back door. So, and again, what I find is that for some reason, physicians, it's all about the approach on how you approach them with what you're wanting to do. And again, incorporating a wound care specialist may help facilitate that as well.
Very good. Well, thank you, Kari, so much again. Kari's been gracious enough to offer her contact information, so we'll send that out after. If you guys have any other questions, feel free to contact her, or if you need anything from us, please feel free to email director@CMSA.
Okay.
Oh, yeah.
-ok.org.
Okay.org. And then just to remind you guys, I know we're kind of losing a few people already. When you close out, you will get the survey. Please make sure to fill out that survey. And then I was just going to jump in and also say Miss Debbie Moffett is with us. She just is having issues with her computer as far as sound goes. So just to let you guys know, she's another one of our board members. She's joined us on our call today. She's the occupational health nurse, wellness coordinator, and case manager. She wears a lot of different hats for AAR Aircraft Services. Again, we will be sending out the slides at the conclusion of this. Just to remind you guys, we do have 2 upcoming webinars. For those that you weren't on the call earlier and missed this announcement, we do have, I apologize, got notes in about 5 different places. Dr. Chansom is going to be joining us on October 15th. He is the infectious disease doctor for Integris, located at Southwest Integris. He will be on October 15th, and that will be starting at noon. So we'll start at 11:30 early, and then noon presentation. Mark Pugh will be joining us on November 19th, and he will be talking on trends in opioids and medical marijuana. And just a friendly reminder for you guys, if you don't know, once you've registered for the Zoom through our link, you will get a confirmation email. And in that confirmation email, it does give you the option to click and add it to your calendar. So it's a great feature for those of us that have a lot of meetings and a lot of stuff going on. It will automatically add it to the calendar for you. And in that calendar, it will have the link so that the day it comes up, it will send you a reminder. It will give you an alert. It will also contain the link. So you just have to go to your calendar and click the link from there. So again, we appreciate you guys all joining us. I'm just going to double check and make sure I don't have any pending questions out there real quick because my screen just changed. I think that covers everybody. And if anybody needs anything, please feel free to reach out. Again, we thank you so much for joining us today, and we'll see you guys in just a few.
Thank you, Kari.
Oh, thank you for having me.
Thank you, Kari. We appreciate
I
it.
think our first webinar was without a hitch.
Yes.
Sorry. And thank you, Wendy Curtis, for keeping us all organized and keeping our ship afloat. We would not make it without you. So we'll see you guys in just a few weeks. Thank you.
Super. Thank you. Yes.
I was going to say on the questions down here, oh, it just says, never mind. It just says to the panelists. Never mind.
Well,
Never mind. Never mind.
These are the questions that I was just asked are a couple of things that I can answer. So, and you got an excellent presentation. Thank you, Kari.
Thank you so much. Y'all have a good day.
All right, super. Thank you.